Welcome to the Project Echo, the West Vic PHN Hub, the SPIDAH Echo Network. This is Series 4, Session 4, and it's Tuesday the 20th of June 2023. And this session is entitled The Impact of Diet, Part 2. So I'd like to acknowledge the traditional owners and custodians of the lands and waterways from which we're zooming in from today. We recognise their diversity, resilience, and ongoing place of First Nations people hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect and reconciliation. We support self-determination of First Nations peoples and organisations, and will work together on closing the gap. So my name's Dr. Robert Ward, and I'm the facilitator for these echo sessions. And I work full-time in general practice in Geelong, and I'm also the father of a 26-year-old young man with intellectual disability. I've been involved with the West Vic PHN SPIDAH project to look at the ways to improve the health outcomes of Australians living with intellectual disability. And we've been conducting these fortnightly sessions, working with primary healthcare services to learn more about improving access for people with intellectual disability to healthcare. So over the last 18 months, we've explored many subjects with the help of some amazing specialists. We've had great discussions with the various issues and the barriers faced by people with intellectual disability. We've heard great insights into the topics like medications, reasonable adjustments, communication, consent, and annual health assessments. And these sessions have been available through the SPIDAH site online. And we've used case discussions to highlight these important subjects. 2 weeks ago, we discussed the importance of diet and so many aspects of a person's well-being with Dr. Helen McCarthy. And I'd especially like the food-first approach that she had when assessing a person's well-being. And tonight, we're going to continue the food-first approach and look at the importance of diet in a person's well-being from a speech pathology perspective. So when participants come in, if you can introduce yourself on the chat so we know who's around, that would be really good. And there's a link on the chat just explaining these echo sessions. We'll have a case study because Project Echo is about case studies. And if anyone has a case study they might like to present in future meetings, please feel free to click on the link and provide the Echo team with case studies. Professional development, there's always opportunity for professional development in these sessions, and you can, certainly for GPs, do that online through your CPD app on your phone. There is a survey for people to take sort of pre-session, and that's always useful for the SPIDAH team to work out what's happening and to give them some extra feedback about how we can improve the sessions. So today for our didactic presentation, we're going to hear from Laura Chahda, who's a senior lecturer and researcher in speech pathology at Victorian University. We're going to be joined by panel members, including Dr. Helen McCarthy, who's the dietitian and Deputy Associate Dean of Learning at the College of Sport, Health and Engineering at Victoria University. Wellington, who's a dietitian and PhD researcher, who's exploring the link between community and nutrition and disability research. And we're going to be joined by Cathy Basterfield, who's the founder and consultant speech pathologist at Access Easy English. And we will get around to a case presentation because Helen's going to present a case for us later. So we have had some learning outcomes for this series, which are there on your screen. And I think the important ones are really the reasonable adjustments ones down the bottom. And we've got some learning outcomes for today's session. So, which is to identify the role of the speech pathologist in pertaining to swallowing and subsequent impacts on diet and fluid modification for people with an intellectual disability, and to identify and discuss additional alternative strategies to diet and fluid modification to promote safe oral intake and a variety of meal options, and to demonstrate awareness for the role of the GP in supporting diet and recommendations for people with an intellectual disability. So today's didactic presentation, we're going to hear from Laura about the impact of diet from a speech pathologist perspective. Now, we all know that patients with an intellectual disability can often have a fickle relationship with food. They can have poor food and nutritional literacy and often rely on family or organisations charged with supporting them for guidance on their food choices. Their motivation is often not in line with what we would consider to be healthy options. And we also know that many people with intellectual disability also have many other quite profound physical and neurological challenges to safe feeding. We heard the last session about the significant and often hidden consequences of not thinking about food and diet in a person's health. So I'm really looking forward to hearing from Laura from the speech pathologist's perspective about the impact of diet. So I'd like to hand over to you, Laura, for your presentation.
Can I just confirm that everyone can see that slide? Yeah, great. So thank you for the introduction, Robert. So I'm Laura, and yeah, as previously stated, I'm a speech pathologist who works at Victoria University currently, but I've also had a lot of experience working with the mostly adult population, but certainly working in disability as well, doing home visits and revising mealtime plans. And helping to support in that sort of area of optimal oral intake and eating and drinking. So very excited and happy to be presenting tonight on the impact of diet from a speech pathology perspective. I know that this was already covered already, but just very briefly, I would like to also acknowledge the ancestors, elders and families of the Kulin Nation, who are the traditional owners of university land. So I'll talk from a Victoria University perspective. We also acknowledge all traditional owners of country throughout Victoria and pay our respect to their culture and their elders past, present and future. So just really briefly, some key points that I'd like to cover just in this 10-minute presentation is that I'm hoping that participants will be able to understand the role of the speech pathologist with regard to diet, as well as being aware of the impacts associated with modifying an individual's food and drinks, and being aware of a range of strategies and approaches to facilitate safe eating and drinking for individuals with disabilities as well. So I guess I always do start this in terms of just general advocacy and just education in terms of the role of the speech pathologist, because sometimes that's the first step in terms of understanding what we can do to help support eating and drinking and general diet. Is that speech pathologists are generally involved in 6 main communication domains. So the first 2 are probably self-explanatory and you know listed within our name, but we obviously cover speech and language, but we also have specialties that we can assess and diagnose and treat in voice, cognition and hearing, fluency, and of course swallowing. So just as a bit of an introduction there, but for the purpose of this presentation, I'll just be purely focusing on the role that speech pathologists have in swallowing only. So just having a bit of a snapshot in terms of what we can do and what services that we do provide in that domain of swallowing. First and foremost, we do provide assessment and evaluation. So that would involve a multitude of different tools and strategies that we use or approaches. So usually incorporates things like clinical swallow examinations, instrumental assessments, or you know, cranial nerve assessments, all those sorts of things. We also do treatment planning and intervention. So that can also have quite a range in terms of things that might be kind of hiding in our toolbox. So it can be compensatory, and that's usually where the diet fluid modification would reside. Posture, delivery of meals, or the bolus. So when I refer to bolus, it's really just once the food is in the mouth and getting ready to be swallowed. Or rehabilitative approaches. So it could be regimented exercises or specific manoeuvres that we might implement as well to help facilitate a safe and effective swallow. We certainly do a lot of collaboration and education as well. So we love working alongside of our key partners. So definitely in the setting with working with people who have intellectual disability, support workers who would work very closely with, carers, dietitians who I love to say that they're our work besties, but they really are when it comes to facilitating, you know, optimal diet and nutrition. And of course, the medical team as well. We find them very strong partners, particularly if we're wanting to advocate on behalf of the client or the individual, which I'll talk about a little bit later. and OTs as well to help facilitate any additional equipment or methods to help facilitate independent living. So if we're thinking about swallowing in particular, we're talking about independence in terms of eating and drinking. So sometimes those additional tools, we might refer to the OT to help guide us in terms of what would be the most ideal modification for our individual. We also then continue our reviews and our long-term support. And this is particularly pertinent when we are working with individuals who do have an intellectual disability. So having regular, so could be monthly, could be twice yearly, depending on the needs of that individual, but at the very least annual reviews should really be utilised just to reassess the swallow function and to update documentation and mealtime profiles as well. So in terms of our overall clinical aims, or what we're always, I guess, working towards, is that we're wanting to enhance optimal swallow safety and to reduce the risk of choking and aspiration, and also to identify optimal diet fluids and textures. What you might be aware of, or potentially might not be, is that usually we hit a bit of a roadblock when we're trying to enhance optimal swallow safety and identifying optimal diet fluid and textures, or even aligning that with what the person wants and desires. So sometimes they do contradict one another. And this is where things get a little bit tricky, particularly in that in the disability sort of setting. We want to make sure that we're approaching that with sort of an even-keeled approach, and we're being a little bit more flexible than we would perhaps in like an acute setting, where, you know, safety and maintaining that sort of health status is paramount. Whereas if we're working with someone who has a long-term or permanent swallowing difficulty, we have to start adopting some more flexible approaches for something that's more sustainable for the long term. So having a look at intellectual disability and key intervention approaches for swallowing. So just a quick snapshot there as well in terms of the prevalence of dysphagia. So that's any swallowing difficulties that there might be for a person. In individuals with intellectual disability varies. So it can be as little as 13%, or it could be as great as 68%. What I have noticed is that over time, generally with age, we start to see that upward trend of the individual potentially requiring more speech pathology services. And that could be in part due to, generalized neuromuscular weakness, but it could also be because that person might also have some accompanying comorbidities that might also have an effect on the swallow function. So some contributing factors, and this is specific to an individual who may have an intellectual disability. So there may be a coinciding structural or anatomical change to the oral pharyngeal structures. So if you think about Down syndrome, for example, there might be an enlarged tongue, or there might be a change in that sort of anatomy that might prohibit the, safe and functional swallow. Coordination of swallowing can also become interrupted, as well as sensory processing issues and cognitive limitations that can affect feeding skills. Or it can be a combination of all of the above, or any or all. So it can become really tricky, and we would have to have a look at what those contributing factors on a case-by-case basis. Some general approaches to swallowing interventions. Again, generally with this particular type of population, it is primarily focused on compensatory factors such as modification of diet and fluids. But unfortunately, and what I've noticed in my clinical experience, and even having a look through the literature, seems to sometimes be the only tool that's drawn out. And sometimes that becomes a bit of an issue as well in terms of that long-term maintenance of an appropriate and variable diet and nutritional intake. I know that this is quite a busy slide, and I don't intend on reading it all out to you, but I thought it was really important to also have a bit of an outline in terms of really thinking objectively here about what are the pros and cons of modifying the diet and fluid. So these don't come without impacts, certainly. So Doesn't matter which population that you're working with. I find that a lot of clients can find it really confronting to alter their diet or fluid texture. And then particularly more so with someone who may have an intellectual disability, if the understanding isn't there alongside of it, or understanding of the rationale or reasoning, or if they're sitting around and actually having a look at everyone else, enjoying different textured meals, or they're realizing that they've got quite a limited variety of different foods that they can have, it's not sustainable for the long term. So some things that I just wanted to point out, that of course we do have some pros, and there are reasons why we do modify diet and fluid. So, obviously first and foremost to improve the swallow safety, for an easier mealtime experience, to support hydration, and it can be tailored, of course, to the individual needs. The cons to that is that we do have reduced food variety and texture. And this is very much so where the dietitian actually is a very powerful and important collaborator on this, because whilst the speech pathologist knows a lot about the diet textures, we may not have all of that knowledge to know exactly what particular foods would help to increase all of the nutritional needs. Let's say if that person had limited access to that particular type of food, just given the texture modification. There is a social and emotional impact, of course. So feeling excluded, being frustrated, particularly in those social settings as well. And then there's sometimes that increased dependency as well. So sometimes depending on the severity of the intellectual disability or the extent of the dietary modifications, the individuals may become more reliant on assistance, even with regard to preparing food. So they may start to be excluded from that, particularly if things are getting blended or you're using equipment that may not be deemed safe for that individual to use. But it can also just impact in general upon their sense of independence as well. Then, of course, there are some challenges in implementing those changes, and the compliance and acceptance is one of the biggest issues that we find as well. So there might be that difficulty accepting or adapting to that dietary modification, which can obviously pose challenges in maintaining consistent compliance. So I guess when I'm talking about that, I didn't want to, focus all too much about that diet and fluid modification. We do have to use it, of course, in certain instances, to reduce aspiration pneumonia, or to reduce the choking risk, or whatever it might be that we might recommend that. But there are other options as well. And usually I actually start to investigate these options and try to work through this and leave the texture modification as my last option, if I can. So implementation of other compensatory strategies such as posture, bolus size, speed of delivery can have a huge impact, and even that promotion of independence. So it's a lot harder for someone to take food from someone else and to swallow it effectively, rather than if they were actually doing it to themselves. So doing things like the hand-over-hand feeding, where you can still support, but also have that sort of sensory and biofeedback from that person themselves that they are feeding themselves. There's also that planning and mealtime logistics, which bases a lot of independence around behaviours as well. So reducing distractions, participation in meal preparation. I've always found success as well in grouping individuals together, where if they are sharing very similar diet textures, they can help each other in terms of meal preparation and not feel that exclusion either. But most importantly, it's factoring in quality of life considerations and designing a plan that would be flexible and allows more food or fluid options where possible. So speech pathologists can actually be integral in this planning. So where we have that expertise is that if someone, let's say, requires a soft and bite-sized diet, but really wants to have a sandwich, which isn't included in that diet texture, can we adopt a certain level of flexibility? Can the speech pathologist assess specifically for certain must-have foods and try to work that into a more tailored and individualized plan, and have strategies around that to minimize the risk and optimize safety? I'm aware of my time, so I'm just going to quickly get through my last slide, but I guess flowing on from that last point that I was just talking about, where I find that the GPs are really integral and can partner really nicely with speech pathologists is that, first and foremost, being able to instigate the referral to the speech pathologist. Unfortunately, there are a lot of times in which we are sometimes referred too late, in that potentially some strategies might have been used, but this person might have been adopting some, poor eating habits for quite some time and maybe already be deemed too unsafe or unable to adapt new behaviours at that point. So knowing that things like loss of weight or meal refusal could possibly be an early indicator of swallowing difficulties. And like I said, the earlier the referral, the more capacity the speech pathologist has to work with different supportive strategies. And then we also really rely upon the support from GPs when adopting a flexible and quality of life focused plan. There is a lot of fear, I suppose, around giving someone food and drink that is considered at risk, that, if they're potentially fast eaters, or they could potentially be a choke risk. So sometimes there's that knee-jerk reaction to just be really conservative with their recommendations. But if with a GP backing and being aware of their overall health status and perhaps their, propensity to develop a chest infection even in the first place, or have a fairly low risk factor, we can have a very combined and flexible approach together. I'll just finish off with some quick takeaways. So I guess my main points is that everyone really does have a role to play in support and referral. So it's not just a speech pathologist. We find the support workers are key, the individuals, of course, the GP, dietitians, and education among the whole team is really key as well. So it's not enough just for us to come in and just say, we recommend this, this, and this. We need to make sure that everyone is on the same page and that everyone actually understands the recommendations. And if not, can we provide some additional supports where possible? Communication collaboration is ongoing as well. So it's not a come in, see you once and off you go kind of plan. Seeing someone, being in touch on a regular basis, and even by regular, if I mean every few months or so, that's more than enough for the speech pathologist to potentially be able to identify when things need to be modified further. And also just consideration of alternative strategies rather than the default of diet and fluid modification. So those are all of my slides. So I'll just stop sharing there. So just some questions to pose to the group, or invite any other comments that you might have. But drawing from experience, what have been perhaps some barriers or facilitators for promoting variety of meal options whilst maintaining swallow safety, in case anyone has ever needed to balance those two? And what are concerns around adopting a flexible meal plan with regard to texture? And how can partnerships between speech pathologists, dietitians, and primary carers be strengthened when working with people with an intellectual disability?
Thanks, Laura. That was really interesting. I've certainly got a few questions later on. I don't know if any of the panel had any sort of comments, or whether that sort of sparked anything that people wanted to pursue a little bit more. Helen, was that something that?
Yeah, I was just going to say, I'm getting really, I don't think homesick's the right word, but I'm really missing doing my clinical role now, listening to Laura talk about that. And because I worked extremely closely with speech pathology when I worked clinically as a dietitian in the children's hospitals in the UK. But yet, the quality of life is a massive thing, because Laura's talked about the challenges that people face when they are struggling with particular textures, and they're given advice that they need to change things, or they make the decision that they can't have something anymore. But working with families, I found that actually parents grieved almost as if it was a real grieving process. when they were told that their child, for whatever reason, couldn't have a normal diet because their natural instinct was to feed them. And you know, that's something that they could do that was normal, to feed them, to have them part of the family. And suddenly you're saying, no, they've got to have, they can't have this, they can't have that, they've got to have this, they've got to have that. And you're taking away that natural family social aspect of it. And they just grieved. So yeah, really, yeah, completely concur with Laura. The quality of life and thinking about a flexible approach to the intervention is massively important for the individual, but also for those around them that care for them directly.
I think it's also important because, Laura, you mentioned sort of risk and those people caring for a person. And I suppose it depends what our risk appetite is, doesn't it? If you're an organisation running a disability house, yeah, you may have very little risk appetite for someone aspirating and having a seizure or ending up in intensive care under your watch. You know, as a parent, you might say that that's an acceptable risk.
Yeah.
So, Cathy, is it?
Oh, you're on mute.
Yeah.
A couple of things. And looking at risk, I think, is a really interesting one when you think about rights. And you then see it much more in the adult population who are aware of what the risks are and giving that choice and control. So it's actually not our choice and control. It's actually saying these are the issues, but my quality of life says I actually want this in my diet, and I recognise that is something that is, yeah, it's a risk, but actually I want that in my diet anyway. So whether it's a variation on the textured diet, and how do we go about that? So I think that's one really interesting one to sort of keep in mind about who's making those decisions. And yes, there's organisational risk, and there's our medical risk, and we can cover that by putting it into a mealtime plan and making sure we're training staff. But there's the individual's risk. And I hear what Helen was saying about families want to actually almost give more risky, what we would think is risky food because of that grieving process. But I've also seen it turn around and go, oh, actually, if I have some alternative food source, and now we can have really pleasurable time with the foods I really love and have that lovely interaction time, which makes a big difference. And I think the other one that is really tricky when you're not in a hospital space and you're out in the community is the whole aspiration and silent aspiration. And Laura mentioned about having, risk of chest infections. And it's not just the coughing and the splurting type young people or adults that you get concerned about. It's actually those who are so used to food always going down the wrong way, and that's just how they live. And what risk are they at to being constantly unwell? And particularly often because they've often got a saliva issue as well, so they've often got wet chests. So you've got all these other compounding issues that sit there for those people.
Can I ask Laura, from a speech pathology point of view, would you see people with significant disability who, when you do objective testing and imaging, it looks terrible, but from a clinical perspective, and a practical day-to-day perspective, there doesn't seem to be much going on, and yet you would watch the video fluoroscopy and say, wow, let's not put anything in this person's mouth.
Yeah, I've probably seen both, actually, to be honest, where I'm just like, from a clinical bedside swallow exam, doesn't look all that bad, but this person's consistently having chest infection. So we end up moving to an instrumental and I realise, wow, they're actually been silently aspirating this whole time, or, it hasn't been as effective as what I thought. But on the other hand, I've actually had quite a few people, and this is where we kind of draw back into that risk territory where, the support workers or sort of like the governing structures are kind of asking, I want this person to have an instrumental assessment because we are so frightened of this person eating and drinking every time that we're worried for their health. And then I'll go in and assess, and they sound awful and they look awful when they're eating and drinking, but actually they're quite safe. So hardly anything has actually descended into the airway or nothing at all. And it's really just been like almost like a coping mechanism in that the swallow has not been, coordinated properly, and so they kind of sound like they're choking and spluttering, but it's actually quite functional for them. So it's worked in our favor sometimes. We're just saying this is just a behavior, and sometimes I've written that into mealtime plans as sometimes I'm going to sound like I'm gurgling quite a bit. I am safe. I've been tested and I'm considered safe. So please don't take my food away from me and things like, because people, their instant reaction is, oh my gosh, let's just take away, let's not do anything, or let's put them on the puree food or whatever it might be.
And I suppose as a clinician, when we order sort of tests or investigations, there's an expectation that it may alter what we do. So will there be times where you say, let's not investigate everything? This has been a pattern of the last 10 years, and we've never had a chest injury. It's never a problem. And if we find something, it's going to throw a whole spanner in the works.
I think that's where it's really important to actually get a deep case history, and not just from the family, but also what's happening, say, in the school environment, if the children are at school and they've got teachers, because each person will also assist in a different way. And although, as Laura said, we'll go out and we'll train and we'll teach people, after we leave, they create their own version of what they think that they need to be doing for safety. And so what does that start to look like? And so what's it really looking like for all the different people that are doing that assessment and doing the mealtime assistance?
So Laura, with GPs, how practical is it for GPs to access speech pathology services?
When I've worked with directly with DHS kind of housing units, usually there would be a speech pathologist that's potentially contracted to certain houses. So it might just be a matter of the GP who comes in to take care of some of these individuals. They might just say, I'll put in a referral, happy for you to refer to the connected or contracted speech pathologist. Or you can give just a referral to, like a written referral to the individual, the family in general, and they can source their own speech pathologist. So I always recommend going onto the Speech Pathology Australia website to find a speech pathologist, because you always want someone who's certified practicing speech path and sitting underneath that governing body. Or you can have a look at your community speech pathologist as well. I'm just thinking, Cathy, do you have any other?
Yeah, I was going to suggest too that under the current NDIS is that someone with CP will actually have an NDIS plan, and their choice of control around choosing a speech pathologist. And as Laura said, there's you can go onto our website and find a speech path, but I'd actually be looking for one who actually, so if it's a CP, looking for someone who works with disability, not a hospital-based therapist, because what we do out in the community and at that education point and looking at the risk model that we use would be quite different to what someone who's had a sudden impact, a dysphagia, possibly because of a stroke or something else that's been happening. And so what we would be looking at is quite a different set of profiles to someone like that. So yes, although we're all speech pathologists, people do specialise in different areas. And although not call ourselves as specialists, but it's about asking the right questions. Will you come out to my home and watch the person actually have their meal? Versus, no, you must come to my clinic space and we're going to watch you eat a meal at 11 o'clock because that suits my timetable. No, we actually go out, we go out and do an evening meal, go out and do a morning tea. We sit down with the person in their home, at their school, whatever it is, and have a meal with them and see what's actually happening in that space. I think it's really important to find those, to find that practical space to be doing it. And not every speech pathologist works in the area of swallowing. It's like not every speech pathologist works in other areas.
So do you know, Cathy, if NDIA would fund that sort of assessment?
Yes, absolutely. It's a higher priority than communication.
Yeah. So how do we get that into sort of people's plans and that? Does that have to be? It's
about writing it in to, like when you get us to do a referral, is to actually be writing in saying it's a mealtime, they need to have a mealtime assessment, and it might be from a GP's point of view, it might be because they're getting regularly, they're getting sick all the time. or they're losing weight. I've actually currently got a client who's seeing a dietitian as well, and we're trying to work out, is it, you know, grabbing food because he's wanting more and more food because people are saying, no, you can't have it, or is something else going on for this gentleman? And so we've actually got the dietitian also as part of the deal for his plan. So it's the dietitian and the speech pathologist and the behaviouralist and case manager all working together to try and find what's actually happening here for this young person. And is it something to do with, you know, is it something medically that he's actually unbalanced in terms of, you know, what is his blood saying, and what is his vitamins, and what's this and what's that? Or is it, you know, or is there something else happening that, as Laura said it, you get there so far down the journey that you go, we should have been chatting to you guys, you know, 2 years ago, to try and find out what was happening. Yeah.
I thought the other interesting comment you had, Laura, was that people, as they get older, may have more risk. Because I imagine that people have a lot of contact with speech therapists or speech pathologists early on in their life when they're children. And these young people, and the more and more down the system and the older they get, the less and less contact they would have. And it's almost like, well, they haven't seen a speech pathologist for a long time. They obviously don't need to see someone. I suppose as a GP, it's something that I need to be more aware of, that the ageing population, that the risk increases.
Yeah, absolutely. And I mean, you know, sometimes for obvious reasons, in that, you know, as we age, we may tend to, you know, develop other comorbidities. So I've worked with plenty of people. So I work towards that other end of the lifespan. My research and clinical, I guess, interests are in palliative care. So I'll work right till the end. But I do notice that I've worked with many people who have intellectual disability but may also have a coinciding dementia diagnosis, or who have also had a stroke, or have had something else that has occurred that compounds the swallowing difficulties even more so, or even like simple things such as your loss of quality of dentition or loss of dentition altogether. So if I'm working with someone who no longer has teeth, and previously they were able to, you know, kind of break down food even if it was a bit uncoordinated, now it's deteriorated even further. So we do, yeah, I do tend to see more older individuals that do require more and more speech pathology services. But again, it's kind of what Cathy was saying. You know, we should have probably been involved and in the team from a long time ago. But perhaps for whatever reason we've lost contact, they've gone into a different stream of care services or whatever it might be, and then they're finding themselves requiring our services again. But yes, I just did want to say it is very important to kind of do your research to find the right speech pathologist as well, because as I'm sure with many, you know, other allied health areas, sometimes people will say that they're all-rounders and can treat and see whoever they can. I'd call BS on that completely, because I focus clinically on one area and I try to make myself really good in that clinical area, but that also means that I lose touch in other areas. So I'm not going to start to pretend to say I'm a pediatric clinician or I can just step in and do whatever, but I kind of highlight where my strengths are. So I think particularly with like NDIS as well, I think I've found quite a few all-rounders that might take on clients because it, you know, for whatever reason, for more profitable reasons. But yeah, it's really important just to make sure, do you have, experience working with this particular type of condition? And you can actually do that on the Speech Pathology Australia website. You can actually type in particular specialties that you want your speech path to be well attuned to, or particular diagnoses or particular range of practice areas. And it'll generate a list of speech pathologists who claim to have that expertise.
I was going to also say, pick up what you're saying, Laura, around dentition. I think that's a member of the team that gets forgotten in this conversation. And there is now the dental practitioners actually do offer a specialist dental service. Yes, and we regularly come across people with intellectual disability, people living in supported accommodation, who are supposedly being left alone to clean their own teeth. which is very poorly done, or maybe a support worker is trying to support someone, but they have never been taught. But under your NDIS plan, you can actually request a dental technician once you've seen your dentist. So there are specialist dentists now who will see people with intellectual disability. They're used to seeing people in their own wheelchairs, not their, not climbing up into the dental chair. They can come to the house. But, having ill-fitting dentures as much as having poor teeth and poor dentition. And, when was the last time you saw someone with intellectual disability have braces? But, they'll often have an overbite or an underbite that's not being dealt with, where someone in the mainstream community might have had that dealt with. And, why are we ignoring these other coexisting issues, which would actually, might actually make a big difference for an individual, and if not for their meal times, for their self-esteem and for their saliva control. And I think that that's one of the biggest issues that we have, is we go, oh, well, that's just a disability, and it's all just part of their disability, when in fact, every small aspect that you would think about for someone who doesn't have all those diagnoses, you would have referred off to get that checked out. And I think we need to be much better and much more aware of saying, well, actually, no, that's actually a poor formation of mouth and oral care. We need to go and have it looked at and considered and fixed up.
Yeah,
I absolutely agree as well. I think particularly with oral health, like I did want to specifically mention that, because it is one of the pillars of I guess determining aspiration pneumonia risk factors as well. Mm-hmm. So and I guess thinking about it from a community speech pathologist basis, or particularly working in intellectual disability, when we're trying to assess, well, what is the likelihood of this person developing an aspiration pneumonia if they're not necessarily the safest eater and drinker, oral health will be one of those first things that I would look at, because if there is poor oral health, that's actually one pillar there that increases that person's risk. That person is not mobile as well and unable to kind of get around and, sort of clear or open up the lungs, or doesn't have an effective cough, or has overall poor immunity. All of these factors work towards that person's increased risk of an aspiration pneumonia. So it's not necessarily just even that swallow function. We look at everything that can possibly interplay here. And then sometimes it might even just be one of those things where that, if we can fix up that oral hygiene, or if we can sort of get that posture going, or get that person moving around as well, then maybe we can be a bit more flexible as well with the food options too, because it offers that extra layer of safety.
And I think that's where dietitians are really good, particularly when you get into that dentition space, and then you start to get the, like you're getting really ropey saliva. That sounds disgusting, but it makes a big difference to your swallow when you've got ropey saliva, or you've got a really dry mouth all the time. And the dietitian can really help work out, well, what's a natural product or a fluid that we can actually give this person that's going to provide that natural ability just to fix some of those issues up. So rather than the GP just saying, oh, here's a medication for fixing up and fixing our swallow, which can then create a whole lot of other issues, maybe there's an unnatural outcome that we can find, where we're looking at, maybe a different sort of, a pineapple-based juice or an orange-based sort of juice to actually help break down the enzymes of your swallow. All these little bits together. And I think that's why it's really important that all these elements do work together. And unfortunately, at the moment, under the NDIS, is that it's really hard to get that group of people together to have those conversations and bring Helen in and go, well, actually, this is the issues from my point of view. These are the issues, because under an NDIS plan, you've got to pay for all those people to do that. And we used to do that when we used to work in, big organisations. We'd have case meetings. Didn't often get the GPs there, but, at least the allied health team would be able to nut out those sorts of issues and explore them, cross-collaboratively, which I think is just really, really critical, when you've got these really complex issues around swallowing.
I suppose that's all about the funding, isn't it? Because general practice is funded by Medicare, so we don't want to go to a meeting. And now everyone's funded by the NDIS, so probably no one wants to go to a meeting.
Well, we want to go to a meeting, but often the parents don't want to pay, or the trustee doesn't see that that's a valuable part of the service provision. They think that it's all about the face-to-face.
Yeah, just going back to some of the points that we discussed a couple of weeks ago was about the fact that that collaborative working was so important when we're dealing with something like what a person eats, because it's not just about as simple as what they put in their mouth. There are so many interplaying factors, but actually nutritional care or food is a basic human right. And if there is a medical condition, whatever that is, that's preventing a person actually being able to access and consume and utilize food the way anybody would, so if they need a modified diet because they've got raised cholesterol, if they don't have a disability, they would be getting that on Medicare. Why does that have to come through NDIS? If they stroke, they would get that on Medicare. They wouldn't necessarily have to go through an NDIS plan to get that. So I think I think there is big problems with the way our services are funded at the moment, like you say, Robert. And I think there's so much we could do better if we took a step back and actually worked out how to do it better.
I hear the term working in silos a lot when I've been in this space, and we all seem to work in a silo and don't communicate as well as we should do.
Yeah, and I think just that word communication, I think, Robert, is the thing that Laura mentioned around mealtime is social. And we talk about the risk profile and all the rest of it, but if you've got someone who the staff are really worried that they're going to choke all the time, and we're saying, well, actually they need to be in a less distracting environment, but in fact this person wants to be sitting up at the table with everyone else, but they're being shoved down one side and someone is saying, I'm going to talk to you over here when you're not going to get to join in the conversation over here. That to me is a big, when you think about it, you go out with your friends, what are you going out with your friends for? What's the most enjoyable thing? Is to go out for a meal. And then
I'm conscious of the time, and Helen, we were going to have a case presentation, but I'm actually thinking this conversation is quite good, and it may be better to continue with this, if that's all right with you, and then that can stay on the recorded information for people to look at later.
Not a problem at all.
Is that all right? I was wanting to particularly ask Cathy, with the quality of care of people that care for people with intellectual disability, and I'm thinking in specialist accommodation, the skill sets and education of that, how important is that? Or how as badly is it done, or how as good is it done? Or
it's really tricky because there is no qualification that you have to be a support worker, but they do encourage you to have a Certificate 3 or a Certificate 4 in disability studies, that sort of support worker thing. But each person is an individual, and as a therapist going in, you might only have a 1 hour of this person's life, and you might only see one support worker when there's 10 support workers that actually rotate through the house. So that's one of the big things. There's a huge population of people who are support workers who have English as a second language. And so the way we convey our information is really, really critical. And that's where I do a lot of my specialisation these days, is in thinking that we've got 44% of the adult Australian population who struggle with reading, and it's 10% worse for people with English as a second language. If you talk about health, it's actually 60%. So most of us struggle to understand what we get given. So we give support staff really complex information and complex ideas. And they're also supporting 5 people, not just the person that you're particularly interested in. So they've got all these competing factors which just make it so, so very difficult.
And I also imagine that's a transient population of carers. So you get another carer, you could do a training session for all the current carers.
Yeah.
3 months later, there's 3 new ones who,
or you get the
Chinese
opposite.
Whispers about what.
Oh yes, you do, certainly the Chinese Whispers. But also too, you might get the opposite, where the house staff have been really, really consistent, and they've got into habits a bit like Laura was saying, oh, this is just what we do. Well, that's not good enough either. And trying to change, so it's actually culture. So you're now working with, you're trying to make cultural changes, and it'd be really interesting to know what medical staff could do in that space? Because, I mean, it must be really difficult for you, because someone might come in to you and it might be the casual because the client happens to have a doctor's appointment, or it might be the key worker, or it might be just one of the other staff.
Yeah.
You know, and in fact, the piece of work that they've done in the dental space is actually trying to create a form that the key worker, if they don't happen to be there, is filled in, and the dentist fills it in too, as to, you know, this is the expectation, these are the issues. But, you know, I mean, this guy, the client I saw today, well, not, I didn't see today, the dietitian saw today, and I was speaking to her on the phone just before, and they'd come in with the client, but they couldn't tell you really what the eating plan had been for the last fortnight. So that's now they have to go away and do that. So, you know, that's going to be delayed again. So, you know, how do you, you know, prepare them? I've been talking to them already about, you know, you need to be telling them how much fluid he's drinking and what is he eating. You know, the dietitian needs to have that when you walk in the door. But they don't.
But also, the important thing is communicating with the patient, isn't it? In a way they can understand.
Yeah. But this is
you have to eat something totally different to everyone else, and it's way different from everyone else.
Yeah.
And we're not even giving it to them communicating in a way that they can understand or retain.
Yeah. And many of them do this sort of work because it is all lovely, you know, face to face, and it's interacting and all the rest of it. They don't want to sit at a desk and be on a computer and all those sorts of things. So they see that as their value, but it's also what they see as their role. Do they see their role as cooking and cleaning, or do they see their role as quality of life? And I'm sure Laura's seen quite a lot of that in her work as well, in that sort of space. And Helen, by the sounds of it, with what you're doing around, you know, what role do they see and what impact does that have on the client in things like going out for a meal at a nice place that they want to go to, versus we go at the local pub because that's where the sport workers know.
Yeah, and have the meal that's not necessarily the nutritional.
Oh, yes. Well, I've seen what's been in a few fridges, but it's interesting. That's an interesting meal choice. Right, okay. Not sure about that. But then also too, I had, as OT, I met many years ago when I was first a young therapist, and she said, we need to be careful they're not putting our white middle class lens on everything here. Okay. So we need to really be thinking about what it is that our perception is around the sort of food that is appropriate for this person of their culture. And yes, you know, Helen with her diet, you know, the dietitians and the dietetics is really important, but we need to be a bit broader around the lens that we look at things and look at, well, how can we make sure someone's getting a full diet and they're educated enough to make those choices and still choose to go down some other pathway because that's the easier food to eat.
I certainly know in my household the food choices my son has may not be the most nutritional. Thank goodness he likes broccoli. That's his green vegetable. That gets included on a lot of things. I can tell you. All right. Anyone else have any other? We're sort of coming to the end of the session. I think. I'm sorry, Helen, we didn't do your case study as much. But did anyone have any other sort of comments as we come to the end of the hour?
Only just excellent discussion from me. Thank you so much for all participating in it. I think it was a really rich discussion. And the only thing that I would want to add in is that I think that NDIS sometimes detracts from primary healthcare professionals providing that wraparound support that they need to be doing from a clinical perspective, so that the right people are involved at the right time for the person, and that it is an individual plan. So one of the things that we certainly has emphasised as part of the SPIDAH project, and seems to have been taken on notice a little bit more by the Department of Health and Aged Care, and certainly through MBS items, that there will be more opportunity to actually have case conferencing involved. And again, how we can get the right people like speech pathologists or OTs or the relevant people to support the people, inclusive of dietitians as well, because we think that they aren't utilised as much as they possibly should be. Thank you, everyone.
Thanks, Kerry. Look, I'd like to thank everyone for attending today, particularly Laura for her presentation, for Helen, Monica and Cathy for your contributions. Just remind everyone about the health pathways that are available, and there's quite a few on intellectual disability there to use. The case study submissions and the evaluation slide there. I'd like to thank the SPIDAH team for all their hard work, Jade for doing all the slides, and Varel for turning up and supporting us. Hi Varel. That's good. So this is the last session for this section of presentations. So we will be back next term, maybe in a different format yet to be decided. So I appreciate everyone. I certainly appreciate all the people who've been in the panel discussions, because we've had some really interesting discussions. I've learned heaps. So thank you very much.